Hey guys, my name is Jesse Moore, and currently I work as a nurse in the cardiac ICU at Barnes Jewish Hospital. I set up my presentation on the cardiac surgery step down floor. It's actually 5200 is the name of it, with the manager Jody Gordon. I talked with her, trying to find out a suitable topic for the presentation, and realized that her floor and the nurses were going to be receiving a new patient population very soon. Patients who have undergone transcatheter aortic valve replacement, different from the standard way to replace an aortic valve. Because typically the only way prior had been an open surgery where they crack the chest open and replace the aortic valve from outside of the body. But within the last 10-15 years or so, this TAVR procedure has emerged, and it's a much less invasive way to correct severe aortic stenosis. So after talking with her, I realized this was a good topic, so I set up a day where I could come give a little presentation on the procedure itself. I described in one column how the procedure was performed. Next column, I listed the four main complications which can arise after the TAVR procedure. And then the last column gave nursing care and considerations and showed them how the patients typically progress and how to take care of them. So in the first column, I described the procedure in detail. So how they perform the TAVR procedure is they'll place two medium-sized sheaths in one side of the leg, arterial and venous. Through the venous sheath, they'll float up a transvenous pacemaker into the right side of the heart, right ventricle, which they'll use to aid with rapid pacing during the procedure. And then the smaller arterial sheath they'll use for pressure monitoring across the aortic valve. And then in the other side of the leg, they'll place a large, typically a 18 French arterial sheath, which they'll use to advance the new aortic valve and deploy it. So how it works is right before they're ready to deploy the new valve, they'll rapidly pace the heart about 180 to 200 beats per minute. It kind of creates a large opening across the old aortic valve, and they'll position the new one right in place with fluoroscopy and then deploy it. After that, they'll remove all the sheaths, remove the pacemaker, and then transfer this patient to either the PACU or straight to the ICU. So the next column, I listed the four main complications which can arise after the TAVR procedure. First and most common is bleeding, hematoma at the access site, and then at the underneath that, stroke is another possible complication, as well as conduction abnormalities, and then delirium. So those are the four main complications that are most commonly seen. Last column, I listed nursing care and considerations for taking care of these patients. I listed how often they'll perform pulse and groin checks, which is every hour, and then visualize each site at each access site for any hematoma, bleeding, perforation, loss of pulse in the distal extremity, as well as close monitoring for any heart rhythm changes. I showed that one of the possible heart rhythm changes, atrial fibrillation, is typically seen around 48 hours to a week after the TAVR is performed, and then showed that strokes could be as common as up to 1 week after the procedure. So it just showed them what side effects to watch out for. So I think it was a pretty good topic. The audience for the presentation were the nurses who were working that day. I showed up, gave the presentation, and used the poster as a sort of a guide to guide the presentation. After it was done, I left it there, so any staff that weren't present were able to take a look at it. I told them if they had any questions, they could always call up to the floor that I work at, and we'd be more than happy to answer them. So what worked really well was probably the experience that I had had previously with taking care of these TAVR patients, because typically these patients would come to my floor after the procedure was performed. So I've been taking care of these patients for about 2.5 years. So it made me very familiar with what's to be expected and what complications would arise during the care of them. What I learned in the process is really how much work really goes into presentations and poster boards for projects that nurse educators have to present to their staff. Let's see, if I would change anything about the procedure. I don't know. I can't really think of what I would change. I think it went really well. I think it was effective overall. And then some of the takeaway points from this experience are, I guess I feel better about giving a presentation should I ever need to in the future. And being comfortable with the topic really helps too. So if I ever have to give a presentation, I'll try to be as prepared as I can. But overall, this is a good experience, and happy that this is the last class though too. So, all right, thanks guys.